Navigating Your Health Today is pleased to introduce Dr. Deepak Shrivastava. Dr. Shrivastava comes to us with a wealth of knowledge. Board certified in pulmonology, respirology, internal medicine, gerontology, and sleep, Dr. Shrivastava shares with us today guidelines for reopening sleep labs and practical advice on how to navigate your health today through the coronavirus pandemic.
Welcome to COVID-19 webinar series. I'm Deepak Shrivastava. Today we are going to talk about reopening the sleep lab and what are the current guidelines. As the rest of the country is opening in different phases, sleep labs are likely to open. They've been closed for significantly long period of time, and there are some guidelines recently issued by American Academy of Sleep Medicine. I have taken some of the information from the American Academy of Sleep Medicine with their permission pending, and I'm very grateful to them for issuing these great guidelines. First of all, as we open the sleep lab and begin to entertain the patients back into the system, we have to really know the current status of the patients in terms of the COVID-19. If they had any recent contact with the patient or have recently traveled, if they have any clinical symptoms which would suggest that they had exposure to COVID-19, or the result of the diagnostic testing, if it was available and they have gone through that. So there are a variety of situations that have been described by the AASM. First of all is if the status is unknown. I suspect that this is the probably most important status. So the patient is asymptomatic and did not have any exposure or contact with the person who had the exposure to COVID-19 for last 2 weeks, nor did they have any COVID-19 test. Well, we fully realize that there are patients who could be asymptomatic carriers, and we have to be very, very careful about this category. Then the second category is if they have been tested and they are presumed negative based on asymptomatic status, lack of any contact with the person who was exposed or had COVID-19 for last 2 weeks, and their COVID-19 test is negative with low clinical suspicion. That means they do not have symptoms. And this again, we have to interpret with great deal of caution because they could be in a pre-symptomatic transmission state or asymptomatic carrier state that could be dangerous. If the patient has been self-quarantined, so they are staying home and self-monitor themselves for 2 weeks after they had a close encounter with somebody who had COVID-19, or they have recently come back from outside the country or were on a cruise ship or on a river boat. These are all high-risk patients and have to be carefully evaluated that whether they are allowed to come in the sleep lab or not. And then is the higher level of category, which is presumed positive. So they are symptomatic. That means they have fever, cough, shortness of breath, the traditional symptoms that have been discussed, but also the additional symptoms that have been described lately are the abdominal discomfort, nausea, or diarrhea, or taste and loss of taste and the smell. Or they have positive or pending COVID-19 test. That means the test is done, but the results are not available. Or presumed recovered. So patients or somebody who had actually exposure to COVID-19 and they became symptomatic and recovered, then how do we define recovery? They have to have at least no fever for 72 hours. That would be 3 days without any medications to reduce the fever, and no other symptoms, or their symptoms have improved in last 7 days since they've had the first symptom. Or alternatively, they have no fever without the use of the medication to reduce fever. Their other symptoms have improved and they have 2 negative tests 24 hours apart. Well, I suspect that that situation will be a little difficult to get due to our testing capacity. and we may not get that. So you have to be very careful in interpreting this recommendation and act accordingly and interpret it accordingly. Then one has to screen the patient. So once we categorize the patient, then the patient has to be screened. And as we are screening the patient, we also have to realize that if the patient cancels or misses the appointment because they have a respiratory problem, or we cancel them, there should be no punitive action against the patient in terms of not giving the appointment once they get better or charging a fee, etc. Screening of the patient has to be done in 2 steps. First is before they come in for their in-person appointment to the sleep lab, and again, second time when they appear at the facility and before they enter the facility, whether it's a hospital facility or whether it's an independent facility where the sleep testing is done. So the pre-screening prior to appointment should be done with the electronic media so that there's minimum contacts, i.e. phone calls, electronic audio-visual meeting, or online tools if one is available. They should be reviewed for symptoms: fever, cough, shortness of breath, abdominal symptoms, nausea, vomiting, diarrhea, or loss of taste and smell. Their COVID-19 status should be reviewed, just like we reviewed a few slides ago. And if they are high suspicious of having an infection based on the review of the symptoms and other information, they should be rescheduled for future evaluation. Screening at the time of the appointment is not only the above mentioned questions and interview, but also checking the temperature and screening the patient again for the similar symptoms and their test results, just as we talked about it. I would like to emphasize again here that if they had a COVID-19 test and result is pending, that is still considered high risk. So again, if they belong in that category, reschedule the patients for future reassessment. And then, of course, as you refer them for future diagnostic testing and clinical care, provide some supportive measures for sleep apnea patients if they are symptomatic and at high risk for having sleep apnea, position therapy, avoiding alcohol, and other recommendations, avoiding drowsy driving, for example. The staff is equally important in this scheme of things. So healthcare personnel and office administrative staff must be routinely screened, not only with the symptoms that we have reviewed, but also the temperature checks twice daily. And if they are symptomatic, they should be sent home. Adopt a flexible, fluid scheduling depending on the availability of the staff and the number of patients who are scheduled on a given day. And the staff, if you are working with a lower level of staff numbers, corresponding numbers should go down when you are scheduling the patients as well, and then give staff frequent breaks so that they are not overworked. There has to be screening policies. Now, we all have different policies in sleep labs, but given the COVID-19, we have to make some extra additions to the policies, especially about sick leave policies, so that the staff is not scared of having any punitive action against them. So the policies should be non-punitive, flexible, and consistent with the local public health policies. Allow all the personnel who are symptomatic or ill to stay home and remind them that they should not come to the work if they feel that they are ill. And then there is screening with the point of contact testing. So when they come in, they should be able to be tested within a reasonable time frame before they go and provide healthcare to the patients. All the healthcare personnel, cleaning staff, other staff should also be regularly screened with a diagnostic test if the test is available. Let's talk about infection control. There has to be a designated staff member who will be regularly following the COVID-19 updates from the state health department and local health department, because the situation is changing by the minutes and a new recommendation can be easily missed. Use telemedicine where available and appropriate, and then limit any non-urgent in-person visits. So try to do the business by the electronic media as much as possible. Utilize the telemedicine or other electronic distribution system for documentation or filling out the forms, pre-procedure counseling, consent and screening, and for post-procedure counseling to the maximum extent possible based on the availability. And I think it can be very easily done. CMS has recently allowed just simple telephone call will take care of the business, and it can be billed as face-to-face appointment. I suggest that you review that documentation that came out approximately 2 or 3 days ago. Within the facility, of course, the common sense social distancing, minimizing the time in the waiting areas, space the chairs 6 feet apart, maintain the low patient volumes, reduce the face-to-face contact time, consider having patients to wait in their cars instead of coming and waiting in the waiting areas. Avoid the lines in the check-in, check-out that can be done over the phone, and complete as much instruction as possible over the telemedicine, telephone, or audiovisual media that can be done. Whenever possible, limit the access of the family members to the lab. Only allow family members who are assisting the patient in a way that nobody else will be able to do. Any non-patient visitors should not be allowed. Only allow healthcare providers if they are going to provide service. For translational service, for language interpreters, remote access is recommended. COVID-19 sign and posters should be displayed at the entrance and other places to direct the patients and give them instructions by reading rather than by discussing face-to-face. Provide instructions on hand hygiene, respiratory hygiene, and covering their cough, the common things that we do as universal precautions. Also have the ample supplies available in the waiting area and the sleep lab. That includes tissues, hand soap, waste receptacles, and alcohol-based sanitizers. Review with staff all the procedures for infection control, cleaning and inspecting all patient-related equipment after use, clean reusable medical equipment according to manufacturer's instructions, and the CDC recommendation for environmental cleaning and disinfection. Personal protective equipment is extremely important. You have to have enough supplies. The clinical staff, administrative and clinical both should wear the surgical face mask at all the times. Patient should wear their own personal cloth face covering to protect the staff. Ensure appropriate use of PPE by a sleep technologist and clinical staff during patient interactions in accordance with the current state and federal guidelines. And those guidelines are updated on a regular basis, and you must review them as they become available. Let's talk about community transmission. And because all the communities do not move on the graph as the same, some communities have substantial transmission, others have less transmission. So depending on what's happening in your local community, let's review what are the current guidelines. So let's say if there is substantial community transmission and there are multiple cases within the communal setting, what we need to do. All patients should be tested in a reasonable time frame before coming to the sleep center, in addition to being screened for symptoms. In this situation, postpone and reschedule all in-lab administration of positive airway pressure titration or split night studies where the positive airway pressure will be used, except in emergency situation. And this recommendation is because the risk of aerosolization and exposing a lot more patients or the people. People in emergent situations are the ones who have either significant illness, which could be life-threatening, and need their CPAP, or they are special situations like ambulance drivers, EMT, nurses, or other healthcare providers. In that situation, review what is the potential for aerosolization, and the technologist who will be working with these patients has to have appropriate PPE. And then recommendation is to utilize a negative pressure room. Many hospitals actually have negative pressure room for tuberculosis isolation, and those similar settings can be done. In IDTF and independently standing sleep labs, this may not be possible. And in that case, postponement and rescheduling is the recommendation. Avoid operating any positive airway pressure equipment in the clinic setting because of the same risk of aerosolization and spreading the infection. And postpone and reschedule all the children and adults except in emergencies, as we discussed earlier. Medicare will cover expenses for the positive airway pressure device just based on clinical assessment and diagnosis of obstructive sleep apnea without a PSG or home sleep testing. At this time, we do not have any guidance from CMS what will happen after the epidemic and pandemic is over to these people. And my best guess is that these patients will be followed up and they were brought in to the lab for formal testing, formal titration to provide and prescribe accurate CPAP pressure, and also look for leak and other troubleshooting that comes with the CPAP titration. There are specific guidelines for home sleep testing, and in the areas where there is substantial transmission, postpone and reschedule all non-emergency in-person appointments for home sleep testing. Conduct the visits via the telemedicine. There are two types of devices when it comes to the home sleep testing: reusable and disposable device. If the reusable device is used, then it must be clean and sanitized according to the CDC disinfection standard and manufacturer's guidelines. And then there is an added layer of precaution that the device should be removed from the circulation for at least 72 hours, 3 days, before it can be sent to the next patient. They recommend considering the use of disposable single-use device if available in your area. Also, the patients or their family should not be expected to come pick up or drop off the device, and professional or commercial service should be used to deliver the device and pick it up and brought back to the sleep center. Provide the patient with access to instructional brochures, videos, or a telemedicine consultation in how to use and how to set up the device. Individuals responsible for these devices which come back from the patient's residence should be very careful and must wear the appropriate PPE while handling the device. Now, if the community transmission is moderate or minimum, there are slightly relaxed recommendations. If there are multiple cases of COVID-19 in the community, then still it is better to postpone and reschedule the in-lab administration of PEP therapy. Unless you can do it in the negative pressure room, as we discussed earlier, it's an emergent situation. And again, don't use it in the open area of the clinic setting. Postpone all PSG in older adults, pregnant, and people of any age with high risk of severe illness, so cardiovascular, pulmonary problems, and hypertension, diabetes. There is a list of 5 or 6 conditions which predispose a person to have severe case of COVID-19 and poor outcomes. In similar situation, you can continue to proceed with the diagnostic PSG in children and adults who are not at the higher risk. And in the same group, you can also have in-person clinic appointments with the precautions as we discussed earlier when you are screening them before coming into the clinic and when they show up at the clinic. Restrict the home sleep testing according to the previously described parameters. Additional options of using curbside pickup and return instead of delivery service. So if delivery service is not available or not affordable, and patient or their family must pick up and drop off the home sleep testing machine, it can be done at curbside according to the recommendation. And if there are any visitors that must come into the sleep center, pre-screening should be done the same way as if they were the patients. If there is no transmission in a community or minimum transmission in the community indicated by minimum number of cases, resume all the in-lab administration of PEP therapy, resume diagnostic PSG for children and adults, regardless of their health status, and resume in-person appointments as needed during the visits. So resume normal operations. Resume normal home sleep testing protocols. It is no longer necessary to restrict the home sleep testing according to the previously described parameters and start normal visitor policy. However, having said that, it is important to continue to monitor the local, state, and local public health department recommendations regarding any secondary or tertiary spike of the COVID in the community. So remember, important point here is to realize that you have to protect your patient and your staff safety at all the times. And it starts from reopening the sleep lab and the interview of the patient via telemedicine before they come into the community, and then everything else follows per protocols. These guidelines are extremely important, and I hope that they are simple enough to remember and simple enough to protect the patient, their families, our staff, and ourselves. Thank you so much for listening. I appreciate it. Thank you.
Navigating Your Health Today is produced by Julia Worrell, the Sleep RN, and Director of Correct Sleep Solutions.